the genesis of chronic pain after a surgery, and we really didn't get much guidance for those patients. Of the 12 guidelines, only one was focused on acute pain. The second was these guidelines were meant to really provide guidance to providers, to medical providers, to the medical field. But they were really taken literally by a number of legislative bodies and regulatory bodies. And so, as is shown on the slide, a number of states enacted legislation, including my own, that really limited the use of opioids by physicians. And honestly, a lot of physicians, I can speak for Arkansas, are frankly scared to prescribe opioids because the number of things they have to do to remain a practicing a provider or a prescribing provider are a little bit onerous. And they're also afraid of some of the retribution if they do it incorrectly. Lastly, that led to a lot of patients really kind of being abruptly dismissed from care, or their opioids being abruptly discontinued, or maybe even quickly tapered. A lot of physicians I've seen have even put up signs in their office that say they don't treat pain. And when you think about it, that's almost a little bit silly because we all treat pain. Pain is the warning system for our body that something's wrong. It's the reason patients go to the doctor. Patients don't go to the doctor because they're having a myocardial infarction. They go to the doctor because they're having chest pain. And as we've done that, it's really caused a sense of tension, really between kind of regulating bodies and legislatures and law enforcement and physicians, between physicians and patients. A lot of this I often see on social media or on Twitter, where patients have talked about physicians who have abruptly stopped prescribing for them or who are undertreating their pain. And then you also have that tension between patients and legislative bodies. And I've been to hearings and other marches and things where patients have said they feel like some of these laws are really preventing them from being treated fairly. Another is kind of how we're using some of the tools that have been created to help us. So a lot of these laws have created PDMPs or prescribing databases, and sometimes those databases can be used negatively. They can be used to discriminate. A lot of my research is on disparities in chronic pain care, and they can be used to discriminate against patients of color or patients who are of any demographic, unfortunately, or patients who are of a lower socioeconomic status, as we've seen in the literature. And this slide really tells a story of kind of what's been happening, right? So, the opioid epidemic started in the 1999 or 2000, and there were a number of reasons for the genesis of that, and that's not really what we're here discussing today. But as these guidelines came out, and as we began to see news media, papers, and other kind of, and really changes in medical education around opioids, we really saw peak prescribing about 2011. And then after the guidelines were published in 2016, we saw a real sharp kind of drop in prescribing. And while there are less prescriptive opioids technically on the street that are prescribed by a physician, we've yet seen a dramatic increase in overdose deaths, even after the guidelines were published. And when you look at the orange line, which is synthetic opioids, or excuse me, when you look at the orange line, which is kind of opioids that are prescribed in a clinic are morphines, hydrocodone, oxycodone, you can see that line has really stayed steady. So even though we've stopped prescribing as much, we have as many patients overdosing from prescriptive opioids as we did kind of prior to the guidelines. And when you look at synthetic opioids like fentanyl, we've seen a dramatic increase, and some of that probably even being due to COVID. So kind of there have been some changes to the new guidelines. And as I talk about them, I'm going to shortly start to bring in the rest of the panel. But there's really an emphasis on evaluation using a biopsychosocial model, which we're going to discuss. There's also kind of much more asking providers to lean on their own medical judgment and to really weigh the risk and benefits and to discuss the risk and benefits with patients, not to just use blanket rules and blanket numbers to kind of decide whether a patient's getting too much or too little. There's been an encouragement of opioid safety. So patient education, harm reduction tools, making sure patients have a true risk-benefit analysis before we start to prescribe opioids, ensuring that physicians are tooled and trained to screen for opioid use disorder and to understand what the treatment recommendations of opioid use disorder is, so that when patients may be having a little bit of trouble with opioids or maybe developing a drug use disorder, that instead of being punitive, we understand how to have that conversation with patients, but also how to get those patients over to treatment. And the last is kind of working toward a safer management style for patients who are on long-term opioids. And that's a lot of what we're going to talk about today. And we're going to really start with that pain assessment. And there's a quote on the screen kind of talking about how complex pain is and all of the different factors that weigh into pain. And I want to start with a question to Yvonne. Kind of, now that we know that pain is both emotional, psychological, and physiological, that there's so many facets that go into pain for a patient, can you discuss a little bit how you assess pain and how you think that those of us who treat chronic pain or acute pain should assess pain in the future?
I'd be glad to. Assessment has always been difficult for a lot of practitioners. And I think you need to understand that by listening to the patient, you're going to get a lot of valuable information that you can use to craft your care plan after deciding what your assessment is. The assessment process really is something to me that doesn't fit a number scale. I think that is something that's really pretty been misused in the past. I prefer a functional assessment for my patient. And so I will ask the patient, what is it you want to do? What kind of goal do you want to set? And so that goal can be something so simple as buying my own groceries or going to the movies, or I'd like to go to church this Sunday. And so when you look at the goal, you have to then come back and reassess it on future appointments and say, how did that go? Was it good? Were you able to sit for a long time in church? Did you have to get up and leave for low back pain patients? So I listen to the patient, I set a goal that's reasonable and one that the patient is really interested in pursuing. Does that kind of answer the question for you? I think so. I hope so.
Yeah, definitely. I wanted to talk a little bit about kind of the classifications of pain. Can you go into kind of, do you look at whether pain is acute, subacute, or chronic at all?
I do, because the acute pain patient is one that you really have to move on, because if you don't treat the acute pain, it can actually morph into something more chronic, much more difficult to treat. So if you have a patient that has a crush injury, it may end up being something like CRIPS, the complex regional pain syndrome, where the patient is going to have debilitating pain for the rest of their life. So acute pain is something you have to treat very aggressively. The subacute, I'm not so interested in, but the chronic I am, because in my practice, I had a lot of chronic pain patients who were admitted to the hospital for surgery. So I did have to deal with them. And, dealing with the chronic pain was often the biggest barrier, I think, in our practice.
Yeah, I 100% agree. And the literature really does show that if you treat acute pain aggressively, then patients actually have less chronic pain. So we need to treat patients aggressively when they're in that acute phase and really kind of try to titrate them off opioids as they start to heal. I really start to look for those patients with the subacute pain, because I think that's that critical period where you can kind of prevent someone from transitioning over to something that can be kind of a lifelong issue.
Yeah, I encourage a lot of pacing. They can't really overdo. If they overdo, they're only going to hurt themselves more.
Can you talk a little bit about the difference between neuropathic and nociceptive? And there's this new concept called nociplastic. Can you talk a little bit about those?
Sure. Neuropathic is really my jam, to be honest with you. A lot of the patients I saw had surgical pain, and you can consider that to be nociceptive. But many of the patients would come in with an undetected neuropathic pain, which gave them that mixed presentation. For example, I had a lady who was saying that the pain was really so severe and the nurses were giving her a large amount of opioids. But what was really going on, and when I talked to her and listened to her in my assessment, I found that she actually had a neuropathic pain that was radiating down her calf. And so then you have to look at what kinds of medications do you use, because you're not going to get as far as you could just by using an opioid with that patient. The nosoplastic is really the pain that we used to call that centrally mediated pain, the ones that really have no really indication of origin. For example, a fibromyalgia patient, which is falling into this category, can't really say, well, when I fell and broke my leg, that's when my fibromyalgia began. It's something that comes without damage to that's discernible. So you have a problem with that, because people tend to think that this isn't true pain or real pain and tend to dismiss it as something that is more psychological than an actual pain. So it's really important to look at what kind of pain your patient is having, because in order to develop a plan of care, you're going to have to look at what kinds of things can I do to help this patient. And you may have to include more medications than just your typical opioid.
Yeah, I think that's really important. And I think that's really what this slide is getting at, is that we really have to individualize our care plans for patients based on the type of pain that they have. And honestly, I think some of it is patient buy-in and making sure that patients really buy into the treatments they have, or that they're going to go through, or that they're going to use to treat their pain. Because I find that when patients are bought in and they believe, I think you're going to have a better outcome.
I think, too, you need to encourage them to look at the combination of treatments that you're going to use. Sure. You may be using an NSAID, and then you may be using physical therapy, but you also may be using yoga or a nerve block. In your practice, I'm sure you use a lot of nerve blocks. Acupuncture, trigger point injections, those kinds of things can all be combined. And so for my particular patient population, I used to use opioid, and then I would use some IV Tylenol if they were not able to take it orally. And that would give them better pain relief. And even though it really presented a financial issue to my pharmacy, I think it was really quite indicative that when we started to get the patients out of the hospital within a good time frame, within an acceptable time frame, that really combining the therapies can provide you some of the best outcomes for your patients.
Yeah, and I agree. I think, as we built our opioid stewardship program here and we started to look at costs, we found that a lot of the decisions that we made when it comes to costs were pretty short term, and that dealing with the long-term effects of opioid use disorder for that patient and for the hospital system can really kind of change the cost calculation in some ways. And so I think you're 100% correct. Kind of the last question, can you talk a little bit about kind of the biopsychosocial model of pain and all of the things that aren't necessarily physiologic that can really affect someone's pain presentation?
I think this is really important. This is really key. You're going to have to get to know your patient and understand what kind of stressors they have, because a lot of chronic pain patients are financially strapped. They really can't afford a lot of expensive treatments or a lot of expensive pain medications. So you're going to have to look at ways of giving them the ability to deal with their stress and how they cope with their issues. And if you're not screening your patients for depression, you really should be, because in fact, many chronic pain patients have depression. And once you treat that, the overall picture of their pain gets better. So sleep is horribly important. If they're not sleeping well, of course, they're going to have more pain. And I really do think that nobody understands how isolating. I mean, we all went through the pandemic, and that was very isolating. But chronic pain in itself is a really isolating phenomenon, because you can't go out and do the things and interact socially the way you might be able to. So you really have to look at all of this with your patients. And my whole thing with my patients was that I'd say, no matter what happens, I'm going to be there. I'm not going to give up on you. So giving them a sense of confidence that I would help them and look through all these areas that they needed help with, gave them a sense of confidence. And we really establish nice relationships that way.
I love what you just said, and I call it giving patients a home. There's chronic pain patients are discarded, or often medicine has failed them, and so it means so much, exactly what you just said, to tell them, you have a home here, and I am going to take care of you, and I'm going to do my best for you, and I'm not going to just send you off to somebody else. And I think that's extremely important in building rapport, and so I'm so glad that you said that. I would love to bring Dr. Durham into the conversation as we talk a little bit about kind of pain assessment and how it should be comprehensive. And so I know a lot of best practices that are out there really encourage a comprehensive pain assessment. So I would love to hear your thoughts on how different types of health professionals can collaborate to improve the quality of that assessment.
Yeah, I mean, I think this is really the gold standard when we're talking about managing, especially chronic pain and acute pain as well. My experience is more in chronic pain, but also with the realization that not all patients have access to multidisciplinary care. It is a luxury for a lot of folks, unfortunately, but it really is the best model that we could hope for when we involve an interdisciplinary team of occupational therapists, physical therapists, pharmacists. In our practice, we also have pain psychologists on board. And it really does give you a really holistic picture of the patient and where they're at. And that is kind of the best way that you can address all the aspects of the way that pain impacts someone's life. And that's how we actually can most effectively apply the biopsychosocial model, is through a multidisciplinary approach.
No, thank you. Yvonne, do you have anything to add?
Yeah, I guess what I would add is the physical examination. I'm really upset when I hear patients say that nobody has actually palpated or moved the extremity that hurts to see what actually is going on. You may find that you have muscle problems rather than a spinal problem if you look at the low back pain in some of these patients. And I do really still think that having a team that you work with is so important. I would go on rounds in the hospital with the hospitalist groups, the med surge, the emergency room, the critical care group, and having that ability to interact with the different disciplines, because we had pharmacists and physical therapists and the chaplain on the team, really was very important.
Yeah, no, I agree with both of you. And I would even add complementary medicine. And if you have the luxury to make that a part of your team, or even a part of your kind of, I would say, referral network, I think it's such a huge value add. I did a chronic pain fellowship, and one of the things I quickly realized was there were all these people I was referring to that were like a black box to me. I didn't really understand retail pharmacy. I didn't understand chiropractic care at all. I know very little about acupuncture. I had no idea what physical therapists did, other than the fact that I had an injury when I played football and I went to one. And so I was fortunate that I just took a day and went and spent time with all these folks. I spent a few hours in a retail pharmacy. I spent a few hours with an acupuncturist and had a colleague who became acupuncture trained. I went and spent time with a chiropractor just so I could understand when patients come in and say, I've had 6 sessions with a chiropractor. I know what might have happened, instead of it just being this kind of thing that's out here that we didn't learn in medical school. And so I would suggest everyone on the call, I think you really do benefit, and your patients benefit, when you take the time to understand all of these different modalities.
Can I add as well? I think we're going to talk about a little bit later about sort of this idea of opportunities for referrals. But I think that's a really key piece of that too. Just not just understanding what everybody does, but realizing that it's everyone's job on the team to recognize when folks need referrals to different providers. A lot of times that just falls on the physician, but as a pharmacist or a nurse, or it's incredibly helpful to be able to recognize when someone needs PT or OT or pain psych or something, even if it's not, you're not considered like, the physician who's leading the charge. If everyone can recognize those roles, it's really crucial.
100%. And also, it's really important for the physician, and hopefully I'm not, to make sure that they ensure that the patient understands the importance of all these roles and what they do and how important they are. And you really set the tone for physical, my physical therapist always talks about how physicians say, like, hey, you have to do PT because I can't do your surgery unless you failed PT before. And when patients go in with that mindset, it really kind of changes their outcome. We had a couple questions that I think were really pertinent to the conversation we're having. So I wanted to go ahead and answer those, or at least bring those up for the group. There was one that asked about insurance company, whether insurance companies cover acupuncture. And I wanted to go ahead and answer that because I have a little bit of experience with that. So Medicare covers acupuncture for low back pain. It has to be a physician acupuncturist. Different insurance companies all have different policies when it comes to acupuncture. I actually learned a lot about this. I have an article that's actually in press that's going to come out in the Pain Physician in the next few months, where we went through every single Medicare and Medicaid plan and went through when acupuncture is covered and for what specific things. So it's very variable, I hate to say, but that's the honest truth. There's another question about when patients can't afford some of these treatments. There's a lot that you can bring with technology. There are a lot of things that you can bring into patient care that we weren't able to in the past. And so with YouTube, with iPhone apps, there's a lot of like mindfulness. There's a lot of other things that you can bring in for patients. And yes, sometimes, unfortunately, patients can't have access to something like a spinal cord stimulator due to cost, or something like acupuncture, but there may be other things that they can. There was one other question that asked about our experience with transcranial magnetic stimulation. I wanted to see if either of you had any experience with that at all in either of your practices.
No.
Yeah.
No. I worked I worked with anesthesia, so I'm a Reiki practitioner. So that's my jam.
Yeah.
Me neither.
And there are a lot of, I'm going to get back to some of these questions, but yes, a lot of these questions are going to be answered later on in the talk. So I'm not necessarily ignoring them. We're going to get to them. We're also going to have a Q&A after. I also wanted to point out that we have made the decision to be very casual. So as we talk, we're going to refer to each other by first names because we're all friends. Now we're going to actually move on and go to the next question. Which of the following drug combinations is a risk factor for opioid overdose? First of all, over 600 responses. That is awesome. I'm looking forward to continue this conversation and engaging with all of you. And yes, opioids and benzodiazepines are a risk factor for opioid overdose. And we're going to get into, we just asked that question to kind of transition into pain treatment. So now that we've discussed assessment, I see there are a lot of questions in the chat about treatment. And so we're going to touch on a lot of the questions that are out there. And I want to start by asking a question to both of our panelists, and we'll start with Melissa. Can you discuss how you build rapport with patients and how you manage kind of your professional relationship with chronic pain patients?
Yeah, it's so important. I tend to follow, what you all had mentioned before too. Like, you have a sort of a home here. Like, I'm here to work with you collaboratively. That's really one of the biggest pieces that I tend to emphasize with my patients, is that we do this together, and we incorporate those principles in some of the ways that Yvonne mentioned earlier and how we assess them. So really, what are your goals, right? It's a two-way conversation. So that kind of starts it off there. And then really valuing the patient's input and information that they give you on what's really worked for them in the past and what's not. I feel like that a lot of times providers don't really listen to what the patients are saying about what their bodies are telling them and what works and what doesn't. And just that it's sort of a journey together in collaboration, and nothing is more important than that, especially when we get into the hard topics around tapering. It really has to be a joint team effort and a supportive environment in order to be effective.
Yeah, Yvonne, I'm going to ask you a little bit of a different question. I think that answer was beautiful. There are a couple questions in the chat about how do you build rapport with patients who really think opioids are the only answer? How do you convince them to trust you and to potentially try something different?
Great question. I think everybody struggles with that one. I guess the best thing I can say is I'm very honest and open with them. And I'm not a person who's going to say you have to try these NSAIDs and fail them before you get an opioid. I will tell them that at this point, their pain doesn't merit an opioid, and I would like to try some other things and combine some things. I'm a real honest communicator, so I'm really straightforward with them, and I set achievable goals, and I have expectations as well. What I don't like is when I start a medication with a patient and they take it a few days and they come back and tell me, well, it didn't work. I didn't like that, so I stopped taking it. They have to trust, and I tell them, you came to me because you had pain, and you have to trust that I have your best interests at heart, and I'm going to do the best that I can for you. But you have to try some of these other things, because your pain really at this point is not something that I think really fits with an opioid regimen. That's not saying that we won't go to it eventually. But right now, I'd like to try something else with you and see how that works. So I don't know if you have some other ideas about that. That's kind of how I do it.
No, I agree. I think it's making sure patients feel heard. And then when patients don't agree with a plan, really digging into why. And not in a judgmental way, but ask them kind of what their thoughts are and kind of understanding. Patients often come to those conclusions based on previous information. And that could be because things didn't work. It could be because things didn't work for family members. Family members had, adverse events. A lot of times, with me, it's with injections or epidurals, and patients say, I don't ever want a needle in my back. And really, instead of kind of arguing with them about the merits of an epidural, it's really understanding, well, what helped you come to that conclusion, and why do you feel that way? And did you or a family member have a bad experience with an epidural? I think that is often helpful. In continuing this conversation, one more question, Melissa, that kind of coming from the chat. As we have, physicians, pharmacists, nurse practitioners, all providers are really time limited. So how do you do this in like a little split second of time?
Do all of the building of trust and collaboration and assessment and all of that. You don't do it in a split second of time. You're limited in your individual visits, but it takes multiple visits and a series of interactions to build trust.
Yeah, no, I agree. It's about kind of building that initial rapport and then building trust over time, just like any relationship.
I'd like to add too. I think
Please.
for patients who are wanting opioids, sometimes they've had surgery in the past and they found the opioids to be so effective for their pain, they just assume that that is the thing they need at this time.
Mm-hmm.
Yeah, no, I agree. I have another question for you, Melissa. I was wondering if you could go over some of the non-opioid pharmacotherapy for chronic pain that you've seen used or you've seen used in your practices.
Yeah, I mean, this is really crucial, and rightfully so. The non-opioids are getting their deserved attention over the last 5 years, as the opioid crisis kind of emerged and the conversation shifted to how do we use anything but opioids. So it's really important to have a good sense of what all the options are out there, like what's in our armamentarium for treating pain, and which ones are short acting versus long acting, which take time for the therapeutic effect to kick in. But they're here for you on the slide. So we have things like acetaminophen, which again should not be forgotten. Our simple analgesics like acetaminophen and some of the NSAIDs oftentimes are incredibly useful tools. I had a patient one time who was an older woman who came in, who was referred to the pain center. She was on tramadol, was experiencing falls. She had osteoarthritis. I'm like, and she was also on an anticoagulant too at the time. And I'm like, well, hey, have you ever tried acetaminophen before? She hadn't. I put her on Tylenol 8-hour. She was fine. And I was able to get her off of tramadol and send her back to primary care. So these are things that like, we can't forget the simple stuff. Of course, we know NSAIDs have incredible utility across different pain conditions. And so those are really nice for immediate, effect. The combination of acetaminophen and NSAIDs has been shown in some cases to be equally effective compared to something like a hydrocodone acetaminophen. And that combo is really a favorite in dental practices. And then incredible tools with our antidepressants, our SNRIs, our tricyclic antidepressants at low doses for pain. And what's so great about using SNRI specifically is that you can kind of kill two birds with one stone. As Yvonne mentioned earlier, we have patients with chronic pain very commonly also suffering from depression. So you can, put someone on something that helps for their mood disorder as well as helping with their pain. Duloxetine has a variety of indications, so it's an incredibly useful tool. And then with the TCAs too, we mentioned earlier how patients oftentimes suffer from sleep disorders as well. We have these vicious cycles of mood worsening, pain worsening, same thing with sleep worsening and pain worsening, and around we go. So TCAs can be very useful, for sleep at a low dose in addition to helping with neuropathic pain. And we have our gabapentinoids, pregabalin and gabapentin, that are indicated for variety of different types of neuropathic pain, and pregabalin for fibromyalgia. And then other anticonvulsants can be used. For example, carbamazepine has evidence for use in trigeminal neuralgia. Topiramate for chronic headaches, chronic migraines. And then topicals can be really, really helpful. Even the topical NSAIDs, so like diclofenac gels we use to incredible utility to help decrease opioid requirements and relieve pain, and our muscle relaxants as well. But the key to these is really always thinking, and it goes back to that, the medication piece is part of the assessment, right? So what else is there that we can add to our multimodal therapy that we haven't tried before? And also looking at each individual therapy and asking yourself, what do I need to optimize? Where is there room to go up? Or there's something that a patient is just on a starting dose on and someone's never moved? So those are all really critical pieces to ensuring optimal pain management therapy.
Yeah, I thought that was an outstanding summary. And, there are a lot of questions in the chat kind of asking, what do you do when you can't use NSAIDs? Or what about patients who say only opioids? And I think you're right. There's part of the assessment is really understanding kind of what all the options are. Can you use topical NSAIDs? Can you use some of these other medications? Especially and also looking at comorbidities, because some patients can have NSAIDs, they can have some of these other medications due to fall risk. and understanding kind of which one is the best for them. I also wanted to, as we're kind of switching gears a little bit, I wanted to ask Yvonne to go through and discuss some non-pharmacologic therapies for pain. We have a lot of questions about things we can do that don't involve a prescription pad.
Yep, these are things that I like to do too. Now, when I tell my patients to exercise, it could be just something so simple as walking. They don't have to go to a gym and start lifting weights. And using sleep hygiene to get a better night's sleep. Not looking at screens, not listening to TV or whatever before they go to sleep. The thermal therapies, heat and cold, can be very useful. In 2014, I had both my knees done at the same time. And I can tell you, I used a topical, one of those little on-cue pumps, and it was very, very good. I used acetaminophen along with my opioid, and I used heat and cold as I was going along with that. And, the postural supports, they don't have the braces around the waist. The research isn't quite so strong for that, but massage is great. If you can get a massage. My daughter was just telling me that one of their insurance plans allows for massages. So that would be something I'd be interested in myself. The cognitive behavioral therapy, that can be done, as you indicated, using a tape or some kind of an app that will allow you to have a relaxation. There's a whole bunch of them out on the internet that you can use. I used music a lot with many of my demented patients. They loved it. They thought it was great. And they calmed down dramatically when the music was kind of geared to their age group. And the pain reprocessing therapy is a new one coming out where you use a practitioner to give you about 12 treatments where you learn to reprocess the way the pain is being perceived in your brain and your response to it. So that's a brand new one. Doesn't have a lot of research behind it, but sounds very interesting. Acupuncture, great. And TENS are very good. You can go on Amazon and buy a TENS, so you don't actually need to go and get one through your PT department. And biofeedback is very good as well. So it just depends on the patient. You have to ask them what they're very interested in. Some of the, if you ask them about one and they're not very interested, that's not the one I'd go with. But I think that you can find something in this list that almost every patient would be interested in trying at least once.
I think that was also a great summary. And a couple of things I want to highlight from both of these lists. One is that no drug is really the kind of golden solution for chronic pain. And the thing that we always have to remember, and I see a lot of conversation in the questions and in the chat, is that when patients get to us, and by us, I mean chronic pain specialists or chronic pain providers, they've failed a lot of stuff. And oftentimes chronic pain is really challenging. There is a neurophysiologic change in the nerves that often causes a lot of chronic pain diseases. And so, a lot of times we've made the mistake of saying that gabapentin is the fix in the same way that we previously said opioids are the fix. And we have to be honest with patients and say, we're going to try this. What you've tried in the past has not worked. And we're going to, based on the literature, we think this has a good chance to help you, but we're going to try it and see, and we're willing to pivot if it doesn't. And I think that really holds true to both the pharmacologic therapies, but also the non-pharmacologic therapies. And also, speaking specifically to gabapentin, there's a lot of questions coming in about gabapentin being controlled and being overused. And I agree. I think I can say when I was in pain fellowship, kind of gabapentin was spoken of almost as the fix for the opioid epidemic. And I think we see that was incorrect. And some of the latest studies in anesthesia have really shown that gabapentin doesn't really have as much benefit in acute pain patients. It may increase fall risk in ways that we didn't think at the beginning. And so we really have to kind of look at all these medicines, look at the situation, and look at availability and look at access, because some patients don't have access to acupuncture and massage. I live in Arkansas, where I'm fortunate, I know 2 really good acupuncturists, but if you live in certain areas, it's a little challenging and more expensive. Moving forward, I wanted to ask Yvonne another question. I think there are also, and you alluded to this when you talked about apps, there are certain things that patients can do on their own that we can encourage them to do at home to treat their pain. Can you talk about some of those?
Well, I've already talked about improving the sleep, and I think that that's really one of the best things you can do. I think that a positive attitude is good, and trying to work with them to get that. Movement and exercise. They can't really catastrophize to the point where they think, oh, if I move, my back is really going to bother me, or my leg is going to get so bad. They really have to look at how they can move effectively. So learning to do that is really good. I think pacing is my favorite there, because pacing really lends itself to allowing the patient to determine what their limit is, what they can do today. And they have to learn that they can't do everything every day, that they have to leave some of the things to another day or approach it in a different way. So pacing, I think, is really, really a good one. The one that they have there, consume wisely. I think one thing that we have all seen in our practices is that patients are self-medicating with alcohol. So in order to really get a handle on that, you have to question them very carefully and softly and very empathetically about their alcohol consumption. So it's not only weight, but it's what they're actually taking in that can somehow damage their functionality. And I don't think they understand that all the time. I think they think that what they're doing has no impact on their pain or their functionality. So it's up to us to kind of educate them into that these are the things that might be helpful for you. But pacing is a really good one, I think, to start with, teaching them how to actually allot their time and energy better.
Yeah, and I want to give a shout out to Dr. Mark in the chat, who used the analogy of a tandem bike, that patients are steering and we have a map and we have tools and we're trying to help them. It's not that we're in control and we're telling patients what they have to do, but we're offering suggestions as to how they can hopefully get to pain relief. I want to send it back to you, Melissa, and ask you, we've talked a lot about chronic pain, but can you, in the next couple of slides, talk about how we should use opioids for acute pain, which is something that really wasn't discussed in the original guidelines?
Yeah, for the most appropriate sort of initial use of opioids is really in acute pain. We have a lot of folks who are taking opioids for chronic pain who have been started on it before, but the initial use is really where the best utility of opioids exists. And for things that are listed here, like severe traumatic injuries, invasive surgeries, and then what's really important on this third bullet here is severe acute pain when other therapies are contraindicated or have failed, okay? Because I'll talk about that more on the next slide too. But the other things that come back from the old guidelines, the 2016 guidelines too, are some of these things like using short-acting agents first are preferred, and then on an as-needed basis, the lowest effective dose for the shortest duration. And as we mentioned before, maximizing all these other non-pharmacologic and non-opioid therapies. So my saying in practice is we maximize and we minimize. We maximize everything else and minimize the opioids. And that's a really nice rule of thumb. And again, if folks are on opioids as needed with appropriate use for more than a few days, you may want to have to taper off of it depending on what the dose that they're on. But really think about opioids for initial use for acute pain at this point in time. Probably the next slide. Yeah. And, the new guidelines have some guidance on when opioids are not recommended first line. Now, when I saw this and I saw kidney stone pain on here, and I remember when I had my kidney stone, I was like, Like, hold on. Sometimes we need them for these things. So that's why it's really key of when other medications are not indicated or not effective, or when pain is severe, we may still need opioids in some of these cases. And that's why the new guidelines are it's so important that they're emphasizing the clinician judgment in a lot of these cases, right? But of course, it's always weighing risk versus benefits. There are some studies that show that even at lower doses, there is still some risk for increasing the risk of opioid use disorder when patients are taking them for more than 90 days. So we have to keep that in mind. If someone's on, oh, it's just a 10 milligram hydrocodone, let's not even, worry about it. But once we get past that, 3-month mark, the risk of developing opioid use disorder does increase even at lower doses. But again, it's all clinician judgment, and depending on what is really effective and most appropriate for the patient and what's going on with them at the time.
Perfect. That was great. And I also wanted to address something that's been asked a few times. The slides are available under the resources tab, and they'll be posted with the recorded activity. So all of you will have access to these slides, and we're just kind of using the slides to really prompt a conversation, but there's some great information in there that hopefully you all can take away. Mm-hmm. Melissa, I wanted to ask you one more question about, sometimes we can't transition patients off of kind of acute opioids or opioids for acute pain, and they end up taking them chronically. Can you talk a little bit about how we should assess patients who are on opioids chronically, and then how we should monitor them afterwards?
Yeah, so I actually think that the 2016 guidelines did a fairly good job of this, and it's pretty consistent with the new ones. But, it's really just kind of like general good principles of medicine and caring for and monitoring your patients who may be on drugs that aren't necessarily safe all the time. So seeing them at regular intervals, so they get, roughly at minimum every 3 months, but also, of course, taking into account the social determinants of health that might exist and barriers that exist for patients to coming in and paying for their office visit or getting to you every 3 months. Telemedicine has been really crucial in helping out with some of those issues and barriers in some of my patients. And then tracking the pain, but of course the function, always the functionality at every single visit. When I started out in my practice, we're like, oh, let's demonstrate the value of a pharmacist here, and let's look at pain scores. And then in my patient population, they never changed, no matter what I did. Right? Some folks were always at an 8, and we realized, well, this is stupid. So it's really trying to determine the documented functional improvement that exists that shows whether or not you're successful and whether or not the medications that you're using are actually effective in benefiting the patient. Because look, say, for example, you start a new medication for a patient and their pain score goes from an 8 to a 3. Yay, but they're so sedated that they can't even get off the couch. You haven't helped them whatsoever. So it's not about the number, it's about the functionality, right? And of course, always, we'll talk about some risk assessment tools later on, evaluating their sort of risk for, I don't even really like the words misuse or abuse anymore, but sometimes we're backed into a corner and don't really have another good word to use to describe what we're trying to say in our language. But folks who are at risk of, continuing the medications for non-medical purposes despite their own harm, like maybe that's a better way to say it. And always, like I said, what else is there? What else is there? The rest is on the slide. Those are the main points I want to make. And then, do you want me to keep going?
Yeah, let's talk a little bit about monitoring, if that's okay.
The monitoring, yeah. So we have at our fingertips and our disposal prescription drug monitoring programs, and these have been around a long time. All 50 states have them now, and the laws from state to state and the requirements for prescribers and dispensers vary on what we're required to do as far as looking at the PDMP. I think that's what's really crucial is having a conversation with the patient about what the PDMP is, how it's used, and what we're going to do with it. It's no big secret now. Patients know, everybody knows that we have access to this information for the most part, but it's important to talk to them and say, look, I will be monitoring this database to double check and make sure that you are filling the medications that I prescribe you, and just to see, for me anyway, what I do is I use it for the last fill dates is probably the most useful thing I use it for, to see when patients are due for refills and things. And sometimes that's a way to couch it in a really kind of accusatory way. And then the regular urine drug screening, monitoring, assessing for adherence. So are you actually taking the medications that I'm prescribing you and not taking anything else that's not really supposed to be on board? Having a patient sort of agree to these terms and understand that it's for their safety more than anything, and to understand that's kind of like the rules of the game of being on opioid therapy.
Then the last question, wanted to talk about, really quickly, if you can just touch on PDMP bias, and whether that's something that you think doctors should be concerned about.
Yeah.
Or any providers.
Absolutely. Well, one of the things, before I get to that, the points on this slide is like, if you don't document and it didn't happen, just a reminder from like medical school and pharmacy and all health professional school 101, we did a gap analysis for one of our clinics, and the documentation in the provider notes was 0 if they had checked PDMP. And it's like, we know we did it, but did you, right? If you don't put it in the note, it didn't happen. So aside from that, a little bit about bias. So there's several studies out there showing things that we've known for a long time, that provider bias exists and is a real problem in creating barriers to effective and compassionate and proper care for a whole variety of patient populations, especially for people of color. People of color are subjected to more urine screens, more restrictions on their fills, more office visits. I mentioned earlier the social determinants of health that can be impacted by these red flag algorithms that we have in the pharmacy. I mean, any pharmacist in this webinar knows that a red flag is, well, there's several, but one of them is like if you're paying cash, right? If it's not on insurance, there's a big one. But then also, if you've come from far away to our pharmacy, why? Are you doctor shopping? Are you participating in diversion? But that also can actually contribute to bias and barriers to patient care as well, because maybe people live in a rural area without an access to providers, and they have to come in to seek the care that they need. There's a variety of data showing that complaints about pain and then the provider denying pain treatment are never documented in the medical record. If you're a provider seeing a patient and you don't believe someone, believe what they're telling you, you're probably not going to write it down. And then lastly, this sense of people of color being subjected to this assumed criminality, more likely to be thought of as folks who are quote unquote drug seekers, or more likely to be someone who has a substance use disorder and less likely to be referred to as pain specialists. These are well documented things that is a systemic issue in our healthcare system. And what we have to do as healthcare providers is hopefully in our education and training, we got this at some point, but many people maybe haven't, but have a dedication to checking our own biases over time. And if you haven't had the opportunity to have some kind of like training in this area, I really encourage you to seek it out and start looking inward in some of these things, because it really does impact patient care. And we all want to do good at our jobs at the end of the day.
Yeah, I think that was excellent. And one of the things you touched on that I think I wanted to just highlight is that 24-hour pharmacies or pharmacies with late hours are always in affluent neighborhoods. That's something to remember, that people may choose those pharmacies and drive a little ways to get to them.
Not just that, but we have a real issue with pharmacy deserts, hospital deserts. We've had a huge number of local hospitals closing in neighborhoods that are predominantly lived in by people of color. I mean, it's we could do a whole nother talk on social determinants of health, but it's
100%. Iman, I wanted to bring you back into the conversation, Can you talk about when you consider tapering a patient on opioids?
Thanks. Tapering is a touchy subject with some patients because they're afraid you're taking the medications that help them away from them. So they get concerned that their pain is going to go up. So you have to have a good conversation about the theory or the idea of this taper. If they don't like the medication or they're not taking the medication, you would consider tapering them off. And if you're not seeing any improvement in their pain, why would you keep going with it? So it's important to look at if their function's not improving, their pain's not reducing, why would you keep going? That's the question the insurance agencies ask too. If the patient is starting on something that would be contributory to increase in overdose, like a benzodiazepine, that would be some way to do that as well. If they're not adhering to the treatment plan or engaging in unsafe behavior concerning UDT results, if they're popping positive for things that you're not prescribing, that is a time when you want to consider tapering them off the opioids and screening them for opioid risk disorder. And if they've had an overdose, that to me is a huge red flag. And so therefore, that would be something that I would consider right away. And comorbidities that they have, you might want to go down to the lowest dose. Patients with PTSD and depression, we were right across the street from the big Armed Forces Hospital, and we did have a lot of patients with PTSD. So when you have those patients on there, you want to keep their medications very low. The other thing I think that's important with tapering is if you have surgical patients, that should be part of your plan of care as they're going out the door. They should know that their medications are going to be tapered and that 6 months from now, they're not going to be taking the opioids that they had for their surgical pain. And this algorithm that you've got up there is kind of a nice way to kind of decide whether you want to. So, if you look to the right, if you're having benefits outweigh risks, then continue as you are. If your risks outweigh the benefits, then you can look down to tapering to get a better overall patient, not experience, but a patient result and outcome.
No, thank you. And I think this slide really does a good job of giving us tips for tapering. Go slow, ask for help if you need it, make sure that patients have support, and really be encouraging. Sometimes patients need someone to tell them that they're doing a good job or to encourage them when they have setbacks. And so there's a lot of things that we can do, little small things that can really help patients be successful with an opioid taper. I wanted to take a moment and ask Melissa a question about some of the concerns that you've heard from patients when they're being tapered. I'm sure you've heard them sometimes in both of your roles, both kind of treating chronic pain patients, but also in retail pharmacy.
So the number one question when we bring up tapering is, what else are you going to give me? We figured out a way that where I can live my life and I feel like these medications are doing okay. I've figured out a way to manage, if that's the scenario, right? What else are you going to give me if you're going to take this away from me? And you gotta kind of have an answer, right? And sometimes it can be really tricky because I may be pulling back on someone's opioid dose and replacing it with maybe 2 other meds. And that can be a hard sell sometimes due to cost, due to pill burden. Folks saying, well, I thought we were cutting back on my meds, and you're adding an antidepressant and an anti-epileptic drug. So that's really challenging. But there's a lot of fear there. And what I like to do is really just reassure the patients that we're going to do this together. And just like the previous slide said, the going slow is so key. I have patients where it's been years that I've been tapering them and they're still not completely off, but we look at where they're started and where they're now, and there's a huge difference. And it may just be like 5% at a time, every couple months, every 3 months. And it really does just take patience.
Yeah, no, I that was great. And I 100% agree. It really does take patience. And it also takes really continuing to address their pain. As you said, patients want to know what they're going to be prescribed, and really making sure that you stick to that multimodal approach and use all of the things that can help a patient as a part of their plan. And as your, one of the main reason that patients want to stay on their opioids is because they're still having pain. And so we have to make sure that we're addressing their root causes of their pain. Yvonne, I wanted to ask you, I'm a pain specialist. There's a lot of reasons on the slide, but what's your main reason, your number one reason that you refer to a pain specialist?
Am I doing the right thing for the patient?
Yeah.
The pain specialist obviously has a lot more experience than some of my hospitalists or primary care practitioners. So, you can always use a pain specialist to look at your plan of care, your medications, and they will come up with something better than what you have, or maybe the same as what you have, but you're going to get some kind of an information that can improve your plan of care or confirm that what you're doing is the right thing.
Yeah, that was a great, concise bottom line answer. As a pain specialist, I often tell my colleagues in my hospital system to, the minute you think about it, refer. And I even tell our doctors, the minute you think about prescribing an opioid, refer. Because a lot of times we may have things in our tool belts that may prevent a patient from getting on opioids, that may kind of help with their long-term outcomes where we don't have to taper them off. And so I'd rather see someone early in the disease process than at the end, especially when they're in that subacute phase and we may be able to turn things around. So I agree 100%. We're going to now switch gears and talk some things about kind of opioid safety and opioid use disorder. I'm going to move things along a little bit quickly because I do want to get to some of your questions, because there have been some amazing questions in the chat that I want to get to. And Yvonne and Melissa, I may do a little bit of a lightning round at the end because there are a lot of things that people have asked really quick questions about. But before we do that, I wanted to ask Melissa about opioid safety. So can you talk about, give us your talk track for what you tell patients to ensure that they still stay safe?
So number one thing is to keep your opioids in a secure location, right? It's a little bit older data, but we know that the number one sort of non-medical use for opioids is people who got it from a friend or family for free. Not even necessarily like they obtained it on the street, but because everyone had that prescription in their medicine cabinet for a long time. And then on top of that, because so many folks have opioids in their cabinet, is whenever you're done with it, you need to get rid of it. You need to dispose of it properly. Don't just keep it forever. And then providing folks the resources to know where to dispose of them. October 29th is the DEA National Drug Take Back Day this year. So there's resources you can find online of the sites to send your patients to where they can dispose of it. And then, of course, is naloxone, which actually I can talk about on the next slide more if we want to.
Yeah, let's do that.
So, you'll see all sorts of different indications listed for naloxone, right? So if we think they might have opioid use disorder, or if they're on high dose, but honestly, sometimes that's hard for everyone to remember. Like, who do I give it to and when and why? I mean, for me in my practice at the pharmacy, when I'm dispensing and also when I'm prescribing in the pain center, I just recommend it for everyone. And then that way folks don't feel like they're being targeted in some way, because sometimes you get these reactions like, well, I'm not misusing my meds. I don't need that. I'm not going to overdose. And so the way I describe it to people is like, listen, anyone who's on an opioid, I recommend this. I prescribe it. And it's just that extra safety precaution to have at home in your medicine cabinet like you would an inhaler if you had asthma, or an EpiPen if you had, severe allergies. It's just in case of emergencies, because sometimes things happen. Do you have kids in the house who might have access to your meds? Do you have, I don't know, pets maybe? There's lots of ways to sort of like couch it where folks will feel less like targeted in a negative way and be more accepting and more likely to fill the prescriptions that you provide for naloxone. And so it's really just critical that we get naloxone out into our communities as much as possible as a public health measure for the opioid crisis. But I wouldn't agonize over the criteria. I just co-prescribe no matter what and document it. And of course, the requirements will vary by state, right? And in some states, pharmacists actually have the ability to furnish it or prescribe it without any other kind of prescription. That's how it is in my state if they do like an hour training. So folks can just go to the pharmacy and ask for it without any other prescribers needing to be involved. So it's a really critical public health measure that we need to push.
Thank you. No, I agree 100%. And I'm glad that you brought that out. You can save someone's life with naloxone. I don't want to go too deep into the slide because I don't want to give a physiology lesson, but I really wanted to highlight that there really are neurobiological changes. There's physiologic changes that happen when someone uses opioids. There's a lot of questions in the chat about opioid-induced hyperalgesia. It's something I've seen. It's something I believe is real. As an anesthesiologist, when you give remifentanil, which is a short-acting opioid, you can actually see it post-operatively. And so those changes do really happen. And we have to address those changes when we think about our treatment, which is why a multimodal system is really important. And we also have to think about it when we treat patients who have opioid use disorder. Yvonne, can you talk a little bit about how you diagnose opioid use disorder? And also, in the next slide, can you talk about how you assess risk?
So my whole thing is that they have to follow the plan of care that we've set forward. So if they're going to fail to do that, hey, that's something they've got to have some skin in the game and learn that they have to come to their follow-up appointments. They have to use their medications the way they're prescribed. And so people who have a craving or a strong desire to use, now I used to have heroin addicts in my patient population. So I've seen a lot of folks that have this issue and they just can't help it. They can't stop. They can't stop themselves. And they do have a lot of social and interpersonal problems. Their families are pretty destroyed and they don't have a lot of close contacts. If they're using larger amounts, if they come in and want early refills, and if they're really interested in how to get it and how to use it, then we're having a talk about that. If they can't cut down, well, that's where we got into the tapering discussion where some patients just cannot be tapered. In that instance, I would refer them to a psychologist to see what we've got going on. And if they're really continuing to use it, despite the fact that they're having a lot of physical and psychological problems. So I think it's really important to look at how to screen it too. And I think the next slide kind of goes through that. The opioid risk tool, these tools are really in their developmental stage. They're not as good as they're going to be, but they're what we have to use right now. So the opioid risk is fairly simple. It can go into a computer. So that's why a lot of folks are using it. And the patient can fill it out in the waiting room before they come in to see you. So you have that information. And the risk categories are by the number of questions they answer. And so everybody knows what to do with the low people. You're going to give them the medication, right? And the high people, well, you're going to probably refer them out. But what about the moderate people? And this is where the clinical decision-making comes into play. You really have to look at how the patient is presenting to you, both physically, emotionally, psychologically, what they're telling you. You're going to have to listen to it, asking about previous use of medications and such so that you can get an idea of how that worked out. So if they had surgery, that you can say, how long did you use your medications after you had surgery? So it's, really important to stress that this does not predict addiction, the old term, but really can give you an indication where you might have problems with the patient. You might want to see them a little more frequently.
Can you also kind of discuss how you discuss opioid use disorder with patients? Like if you have someone that you have some concern, how would you discuss that in clinical practice?
Well, if I come back with a drug screen that looks is problematic, I just go in and I talk to them and say, it looks like your urine drug screen is showing a positive for whatever, opioids or whatever, and talk to them about what actually happened and listen to their response. And then have a discussion with them about how, or if they borrowed the medication or they used it. I just ask them, why they thought that was important. And I think it's the open-ended question is really the best. Has opioid use caused trouble in your life or your family's life? And looking at how people have their own biases and stigma, you cannot project onto the patient your feelings about this. You have to listen to the patient. And really, in the long run, patients are going to be pretty upfront with you. Yes, when I go in there with a urine screen that's got a positive response, they're going to talk to me about how that actually happened and why it did.
Melissa, I wanted to ask you also, can you go over some of the options for opioid use disorder treatment for us? Buprenorphine, naltrexone, what's out there?
Absolutely. And it's so important to understand how these medications are used because of some of the things that Yvonne mentioned with our biases that we have. It's really important for us as healthcare professionals to try and reframe the ways in which maybe we were taught or conditioned growing up to view substance use disorders as some kind of moral failure versus the chronic compulsive condition that it is. And I'll give you some examples of why I think this is so crucial. But first, we have buprenorphine. So buprenorphine is a partial opioid agonist. It comes as a sublingual tablet and film. And one of the really cool things about using buprenorphine for opioid use disorder is that it can be an office-based sort of just outpatient treatment program. Folks can fill this at a regular pharmacy, pick it up, and kind of go through their opioid use disorder treatment, oftentimes in a more convenient way for them. And that's versus methadone, which is probably the most well-known medication for the treatment of opioid use disorder. And it carries kind of a big stigma because of that. We used to use methadone a lot, 15 years ago for chronic neuropathic pain. And we were constantly battling that stigma of like, all my friends and family think I'm a heroin addict, because I'm on methadone. But it has a good utility sometimes in chronic pain when appropriate, if you know what you're doing with methadone. But one of the limitations for opioid use disorder is that it's only available through a treatment program. And then another option is naltrexone, which is an opioid antagonist. That can be also a treatment program, or it can also be office-based as well as a tablet or a monthly injection. But one of the important points I want to make about this is things that I've heard where people say, well, why are we using these opioids for opioid use disorder? You're just trading one for another, right? I don't know if you guys heard that before, but there's pushback on wanting to provide those patients with the medications that they need in order to be successful in recovery. So if I've interacted with pharmacists before who don't want to fill folks' buprenorphine because they're concerned about contributing to the opioid epidemic or opioid use disorder, where you're literally impeding people getting the treatment that they need in order to heal and get better. So I think it's really important to know, especially around buprenorphine, because that's what we see most commonly now outpatient, about how these medications are used and how we want to increase the access to these medications for patients so that way they can get the treatment that they need and that they deserve.
Thank you so much for that summary. I want to thank both of you. This panel has been amazing, and I know we have some questions, so I'm going to try to get to as many as we can. But before that, I want to summarize a few SMART goals, which are real short action items where you can apply things that you've learned to the care of your patients and to your own practice. And so when creating a multimodal treatment plan, really align your treatment to the choice and the type of pain, whether it's nociceptive, neuropathic, and nociplastic. Really apply a biopsychosocial approach to pain management. I think that's extremely important. Maximize your use of non-opioids and non-pharmacologic treatments. I can't remember which one of our panelists said, but I think it was Melissa, kind of minimize the opioids, maximize the alternatives. Individualize decisions to continue taper or discontinue opioids. Don't just make blanket decisions based on blanket numbers like 50 or 90 OMEs, like many have done in the past. And really engage your patients if you think you see opioid use disorder, and try to make sure those are stigma-free discussions, and try to make sure the patient understands that you're on their side and you're trying to do the best for them to ensure that they get the best care. If you have a question, you can jump in the Ask a Question tab in the slide viewer. And if you have a question for a specific one of us, please put our name in. But I wanted to do a quick kind of, if you guys can limit your answers to one sentence, there's a few themes that have been kind of in the chat that I want to address. And so the first one is marijuana for chronic pain. What do you think?
I make the patients choose. They can either have opioids or marijuana. If they choose marijuana, that's fine. There is indications, there's literature that supports the use of marijuana for the cannabinoid pathway.
Melissa?
I'm okay with it. In certain types of pain, neuropathic pain, usually there's a THC component that is more helpful, but most folks try CBD. The problem, I'm getting into more than one sentence, is that there's not good standardized dosing. There's not good standardization among products. So a lot of times we don't know what the heck they're using. So that can be really challenging. But sometimes there's providers out there who specialize in this and can be very effective in using those products.
Yeah, I agree. I think it unfortunately right now has to be patient-led because we don't have the research. Second one, tramadol for pain. Yvonne?
I use it a lot for little old ladies, but I'm a conservative prescriber, so my doses would be low, and you can get good effect with low dose tramadol. You don't have to go really, really high.
Melissa?
Sure. Yeah, tramadol, everyone thinks it's like the non-opioid opioid, right? But you just have to remember there's other considerations with tramadol as far as drug interactions and looking at for folks who have a history of seizure disorder. It's not exactly the same as other opioids that we're used to using.
Yeah, I'm going to zag a little bit. I have a palliative care physician who I'm good friends with named Carrie Hyde, who calls it tramadol. So I think at times there's a lot of drug interactions that we have to think about. And so while I do use it, I do really pay attention to the other drugs in their med list. Low dose naltrexone, any experience, any thoughts? Yvonne, you want to go first?
I really haven't used it, but the literature says it's okay.
Yeah.
We use it. So if anyone is not familiar, naltrexone is obviously an opioid receptor antagonist, but at low doses, we think that it also modifies the toll-like receptors on glial cells, which contributes to neural inflammation, which opioids actually act on those toll-like receptors. And we think that they cause neural inflammation and predispose people developing chronic pain. So naltrexone's being looked at as a glial cell modifier. The way we use it is 4.5 milligrams in a compounded capsule, daily to twice daily, but we usually don't use that dose until we've tapered someone off their opioids completely. And then we play it around a little bit with ultra low dose naltrexone at 100 microgram dose for the folks who we can't taper off of opioids completely. And I've seen mixed results with that. Some people do. I have a patient who's like, I love it. I sleep better on it. I'm like, is your pain better? She's like, so it's been really mixed.
There have been a few questions about the best functional tool. So what functional tool do you use, Yvonne?
I like to talk to the patient and ask them, but the PEG is a good question for primary care. That'll actually get to more of a functional description.
Melissa, is there one that you like?
I use the PEG as well in the interest of time. I used to use the brief pain inventory, but it was just so long and unwieldy, and so the PEG is really great.
Yeah, it took a little bit of legwork, but we have built Promise 29 into into Epic for our practice, and so we measure it at every single visit, and it's also helped. We do a lot of research, so it's also been helpful there. Another question: you have a patient who's on both a benzo and an opioid. Do you stop one? How do you monitor them?
What I do is I titrate the opioid down to the lowest possible dose, and the benzo, I really don't like to combine them at all. I would rather not have the patient on the benzo, but if I'm stuck with it, I try to really lower the doses down to where they're the lowest possible.
I usually attack the benzo first because I'm like trying to manage their pain, right? And there's really, I mean, I can't think of any good reason for someone to be on a long-term benzo. They're really only supposed to be for short-term use, but they can be really, really hard to taper as well.
Yeah, no, I agree. We have time for a couple more questions. Melissa, this one's for you. Kind of, how do you address pharmacy bias? So there's been a lot of questions about how there's some pharmacies that won't fill for patients that are on greater than 90 OMEs, or often say that they're out of the opioid. Any tips for providers on the call quickly on what they can do to advocate?
You're hurting my pharmacist's heart, but I know this is true in some cases, and it can be really difficult. I want to defend my profession a little bit just for a second, because community pharmacists are actually, I think, because I'm a prescriber too who works in the clinic, I kind of think they're in maybe the toughest position, right? Because they don't have access to the EMR. They're met with very challenging situations where they don't have a lot of information and have to make a split decision under pressure of whether to fill or not to fill. So it's a very tough position to be in, first of all. And sometimes folks have been burned in the past and are afraid of, legal ramifications and so on. So I completely understand that. But it is very challenging when we're trying to provide our patients with the medications they need, and they're complicated, and we're trying to taper, right? So some people can't be down past 90 MME, right away, or maybe even ever. So I think what's really helpful for prescribers is to really initiate that conversation with the pharmacist if need be, and when contacted by the dispensing pharmacist, to respond and provide the information that the dispensers need in order to make a better informed decision and not feel like they need to, increase any barriers to the patients obtaining their medication. So it really needs to be a good conversation so everyone has the information that they need to do their job well.
Thank you. That was a great answer. And we love our pharmacists. When my 8-year-old son is frustrated that something that he's enjoying has to end, he yells pineapples. So pineapples, we're out of time. So I want to thank both of you. I think this has been a great conversation. And I want to thank everyone for joining us. You can visit CME Outfitters Opioid Education Hub for additional activities on the topic. And going forward, if you would like to receive CME credit for today's program, please complete the post-test and the evaluation. And so I want to thank you all for joining us. Have an outstanding evening. And again, I want to put up the website for the Opioid Education Hub. It's cmeoutfitters.com/RX4Pain. And again, if you would like to receive CME, then please complete the post-test. Thank you very much.